Awesome, thank you. All right, so hi everyone. So today Ashwin and I will be presenting our recent work MedVAE, which is essentially a suite of generalizable autoencoders that we've designed with the goal of enabling efficient automated interpretation of medical images. Both Ashwin and I are PhD students at Stanford University, and we're very excited to be here today to present this work. We also wanted to share that this work was recently accepted as an oral presentation at the Medical Imaging with Deep Learning Conference, also known as MIDDLE for short, and we'll be presenting this work there in about 2 weeks. Great. Okay, so the key challenge that we're working with in this project is that in contrast to the natural images that a lot of large-scale foundation models are often trained on, medical images actually often include very small features. So an illustrative example is the presence of rib fractures in chest x-rays, which are shown here. Fractures can be very, very small, making them very difficult for radiologists to spot when they're inspecting images during the course of standard clinical practice. A second motivating example is the presence of microcalcifications in screening mammograms, which are very small calcium deposits that show up as these tiny white specks on the scans. These are actually very important features because they're very early signs of breast cancer. So it's very important that physicians can identify these calcifications when they're present in the mammogram. So as a result of these kinds of small features, as well as several other examples that exist, medical images must actually be collected at very high resolution in order to show these fine-grained details so that an interpreting physician can then view these images and interpret them accurately. However, the key challenge is that having these sorts of high-resolution images poses a lot of computational challenges, specifically when we're working with deep learning methods. So first of all, storing these large high-resolution images to disk will incur very large storage costs, and this is likely to become a very significant concern in the near future as hospitals are storing larger and larger volumes of medical images. And then in addition, training models on these very large, high-resolution images can result in very high computational complexity. In the example that's shown here on the screen, essentially feeding a chest X-ray of size 1024 by 1024 pixels through a standard convolutional neural network can require a very large number of flops just for a forward pass through the model. And these kinds of issues will be further magnified when we also consider larger scale 3D imaging like MRI and CT. And these kinds of issues are also very significant, especially as the use of computer-aided diagnosis tools becomes more and more common in clinical practices, as well as the recent talk just mentioned, newer paradigm shifts towards very large-scale foundation models that have very large parameter counts. So it's important that we address both of these issues as these kinds of models become more and more widespread. So the current gold standard approach for dealing with these kinds of challenges typically involves downsizing images via interpolation techniques. There's an example of that shown on the screen here. In fact, the vast majority of existing models that are designed for medical imaging settings actually leverage interpolation, which essentially downsizes images by computing the value of each pixel as a weighted combination of the pixels that surround it. The challenge, though, is although this works in downsizing the images to, smaller resolutions, the actual challenge is that this can result in the loss of those fine-grained features that we discussed earlier, like those fractures and those calcifications. And so we can see an example of that right here, which is a slice taken from an MRI of the brain. And we can see that especially at downsizing factors of like 16x, so in this case, we're reducing the dimensions of the image by 16x, we're really losing a lot of those granular features that define that brain MRI, making it really challenging to interpret what's going on in the image. We can also view this in a more quantitative lens. So for instance, on a mammogram classification task where a model is essentially tasked with predicting whether calcifications are present or not, we can observe pretty substantial decreases in performance as that degree of image downsizing increases. So more broadly, we can abstract out downsizing methods using a figure that looks something like this. So essentially a source image, and we're considering 2D images in this particular example, will essentially be passed through an encoder. And the encoder could be some type of learned function, so some type of neural architecture. It could also be a fixed function, which is true in the case of something like interpolation. A latent representation will be generated by the encoder, and we can interpret this latent representation as a downsized image. So again, in the case of interpolation, this will be that smaller image that we saw on the previous slide, which essentially reduces the dimensions of the image. And then finally, the latent can be passed through a decoder, which again could be either a learned function like a neural architecture or a fixed function such as an interpolation strategy. And this will yield the original high resolution image back to us at the end, so we can have this entire reconstruction at the end of this pipeline. And so given this entire setup, our key goal in this project is to essentially downsize medical images. And we want to use those downsized latent representations in our downstream computational pipelines instead of the original image. And the idea is that using this kind of strategy can help us improve downstream computational efficiency, as well as improve storage costs on disk when we're storing these images. Okay, so before diving into the approach that we've designed for enabling effective medical image downsizing, I'll now discuss some key desiderata for what we would like an ideal medical image downsizing approach to look like. The first critical criteria that we're really interested in is we want to make sure that clinically relevant features are preserved in those downsized images. Like again, we looked at those examples earlier with interpolation, where some of those key features disappear when we make those images smaller, and that's undesirable. We really want a lot of those key fine-grained features to be captured within that downsized representation. The second critical criteria is that these downsized images should retain sufficient information for enabling high-resolution reconstruction. And this is particularly important if we're wanting to use these images for reducing storage costs, right? So instead of storing those original high-resolution images on disk, if we instead want to store these downsized images on disk, we would need some sort of strategy for being able to reverse engineer them back into those high-resolution images. And this will essentially enable them to still be used for interpretation by clinicians. So in order to accomplish these two goals, we're essentially proposing the use of variational autoencoders. And in particular, in our work, we're developing a novel training strategy that performs two stages of training in order to essentially downsize these medical images while preserving these clinically relevant features. We're referring to this family of models as MedVAE, so you'll see that term used throughout this presentation. The first stage of training, which is visualized here, essentially involves training base autoencoders using just 2D medical images. And the idea here is that we want to just maximize the perceptual similarity between input images as well as reconstructed images using a perceptual loss function as well as a patch-based adversarial objective function. In this work, we're also introducing a domain-specific embedding consistency loss that's based on a 2D vision language foundation model called BioMedClip. And the idea here is that during training, we're essentially applying an L2 penalty between BioMedClip embeddings constructed from the input image as well as the reconstructed image. Now, a lot of existing works that have been designed for autoencoders typically stop here and essentially train using only this stage. But as we discussed earlier, the medical imaging domain is a little bit more complex, right? Because we have all of these fine-grained features that are very critical for enabling accurate clinical interpretation, like those calcifications and rib fractures. And so as a result, in order to make sure that we're effectively capturing all of these domain-specific characteristics, we wanted to introduce a second stage of training, where the goal is essentially to take that latent space and further refine it so that these clinically relevant features are preserved across both 2D as well as 3D modalities. And so here we use two similar but slightly varying strategies in the context of 2D as well as 3D. And so I'll discuss those now. So on the left of this image, we see that in the context of 2D images, so this could be images like X-rays or mammograms, the second training stage will usually take the form of a lightweight training approach that will leverage the embedding space of BioMedClip, the same foundation model I discussed earlier, to enforce feature consistency between the input images and the latent representations. And so importantly, all of the key parameters, so encoder, decoder parameters, as well as BioMedClip parameters are completely frozen, and only those projection layers that are shown in that maroon block are trained during this procedure. And this is essentially forcing that latent representation to capture key medical features that are also present in that input image as visualized in that BioMedClip embedding space. Okay, and then in the context of 3D imaging modalities, we actually do something a little bit different. So using external 2D medical foundations like BioMedClip are not quite adequate when we're working with 3D data because those kinds of models have never been trained on 3D data, and so using that kind of strategy will not be effective here. So instead, in the context of 3D modalities like CT scans and MRIs, the second training stage essentially involves lifting that 2D VAE architecture to 3D using a kernel centering inflation strategy. And then we want to essentially continue training with 3D images. And so as a result, we're essentially focusing on implementing a training procedure that will maximize perceptual similarity, very similar to what we did for stage one. But then here we're going to calculate that perceptual loss and that patch-based adversarial objective at the per slice level, essentially with that final loss term being computed as the mean across all of the slices in the volume. And then ultimately, at the very end of this procedure, MedVAE will yield these downsized latent representations, which are highlighted in the figure here. And these can then be interpreted as downsized images and essentially be fed into training pipelines for computational diagnosis tasks. So the idea, again, is that we can replace the use of those original high-resolution images in our downstream training tasks with these much smaller downsized latents, which should hopefully capture identical clinical features. So in total, we ended up developing a suite of 6 MedVAE models, which includes 4 2D models as well as 2 3D models. Overall, these models are trained on over 1 million images, encompassing both 2D images from chest X-ray datasets and full field digital mammogram datasets, as well as 30,000 3D images encompassing 4 head MRI datasets, 1 knee MRI dataset, 2 head and neck CT datasets, 2 whole body CT datasets, and 2 chest CT datasets. And so in this figure, I wanted to provide a visualization of these MedVAE latent representations as well as their reconstructions. So this is, again, a slice of a brain MRI, and we can see that that latent space captures key features of the brain MRI. And the idea is this specific downstream representation, when fed into downstream training pipelines, should essentially allow that model to learn all of those key clinical features. And we'll demonstrate this in the next few slides with some more quantitative and qualitative evaluations. And so then on that note, I wanted to pass it to Ashwin, who will discuss some of the key results from our work.
Awesome. Thanks, Maya. Great. So yeah, we evaluated our 2D models on 5 clinically relevant 2D tasks. And if you remember from the previous slide or a couple of slides back, the 2D model was actually trained on chest X-rays and fulfilled mammograms. So 3 of our tasks are focused on trying to evaluate like malignancy, calcification, and BI-RADS, which are useful especially for like in these mammogram tasks. We also evaluate on 2 out-of-distribution tasks, which include bone age prediction, as well as with pediatric fracture detection. And the goal here is to get a sense of both the coarse grain as well as the fine grain information that is stored in the latents by being able to use classification as a metric to understand that. So we look at our 2D downsized latent representations. We first have this table in which we're looking at the high resolution images. Our factor over here is going to be the downsizing factor and the number of channels that are actually resulting in our latents. And these are the 5 tasks that are previously described. And they're all on X-rays. And this kind of also makes sense because our training data was also mostly X-rays, but these are 2 anatomies that are different from what we had initially trained on. If we then add the additional 2D tasks, we have a few different baselines. 3 of them include interpolation strategies consisting of nearest neighbor, bilinear, and bicubic. We then have 2 learned approaches, 2 autoencoder approaches from natural image domain, including KLVE and VQGAN. These are both from the Stable Diffusion paper back in 2022, where they first proposed the idea of being able to use autoencoders for image synthesis. And we know here that we not only have a factor of 16, but we also have a channel dimension of 3. Downsizing factor of 60, but also channel dimension of 3. And then 2D MedVAE case, we have factor of 16 and a channel dimension of 3. So channel dimension of 1 and 3. So in case you guys haven't seen this, but the actual results show that MedVAE demonstrates a 10% improvement over this KLVAE baseline at the factor of 16, and an 8% improvement at the downsampling factor of 64. So we note similar trends between KLVE as well as with the VQ GANs approaches. And in particular, MedVAE outperforms both KLVAE and VQ GAN on the two musculoskeletal tasks, which are the bone age prediction and wrist fracture, even the fact there's no musculoskeletal radiographs that were used during MedVAE training. So this shows some level of effective generalization to other types of medical images in the domain. We further note that the interpolation methods for most of these tasks are pretty competitive baselines as well to MedVAE and just using Latents compared to Latents. But our findings do suggest that our MedVAE training procedure yields downsized latent representations that can be used as drop-in replacements for high-resolution input images in these computer-aided diagnosis pipelines while maintaining or exceeding performance. So still very promising results in the 2D domain. In the 3D domain, we evaluate on 3 clinically relevant evaluation tasks. One of them includes a spine CT fracture of trying to evaluate whether or not on this VERSE dataset of trying to evaluate whether or not a fracture exists in the cervical and thoracic spine. We then have the head CT fracture detection tasks, which includes trying to identify fractures in these downsized latent representations to see whether these kind of shifts in the actual skull are actually able to be learned from these classifiers. And our third task is focused on ACL or meniscus tear detection. And this is perhaps thought as both a little bit of a coarser and fine-grained task, depending on the actual symptom. For the most part, for a lot of clinicians, you can pretty easily see these, a tear because of just swelling and other information in the surrounding region. But at the same time, even small meniscus tears may be occurring, which may be quite hard for even a classifier, or even just fine-grained features to understand. But we may have trained these 3D approaches, but we also have a lot of 2D baselines to compare with. So we sort of developed a method here, just evaluating volumetric information in these 2D latents using latent stitching. So let's say we have our volume of our head CT. Then we're first going to slice-wise decompose all the slices. So that way it has just one slice for each, just breaking down the volume into slices. And then we're going to apply our 2D interpolation or learned autoencoder technique to these slices to create downsized in-plane representations. But the thing is that we still are going to have the same dimension in the D direction. So we effectively apply linear interpolation so that we make it the same dimension as what a 3D learned latent would look like for MedVAE. We then show here that this is our first initial graph, similar to the previous graph in the format of having these high resolution images. We then evaluate all these methods on AUROC. We show that on spine CT, skull fractures and knee injury, that there's average around 72. We then take our downsizing factor to a method of 64. So this is 4 in each dimension, which becomes 64 total downsizing factor. And for both KLVAE and VQ GAN, we note a channel of 3 in the dimension. And we see that with 3D MedVAE, we have around a 38% improvement over KLVAE at the downsampling factor of 64, and around 11.4% improvement over KLVAE or at a downsampling factor of 512. So this is pretty interesting because even at a downsizing factor of really extreme kind of experiments of 512 times image compression, we're still able to get some learned signal about these 3 relevant tasks, but especially notably at a factor of 64, the average of what we're able to get on these tasks of MedVAE actually outperforms that from the high resolution image, which is quite promising. And our findings suggest, similarly to the 2D domain, that autoencoders can, 3D training of these autoencoders can lead to high quality latent representations due to the preservation of this volumetric information for instance, fractures spanning multiple slices, especially at the 64 times image compression. We also note that the downsized latents contribute to several efficiency benefits. So we have 3 plots here corresponding to latency, throughput, and maximum batch size. We observe here that in the 2D setting, as the downsize sampling factor increases to 64, the latency decreases by 69. So in gray, we have our high resolution image. In cyan, we have the 2D MedVAE image. And in dark blue, it's the 2D MedVAE with the 64 downsizing factor. And similarly for the 3D volumes, we have the 3D MedVAE at the appropriate downsizing factors. So we see that in the 2D setting, the latency decreases by around 69%, and the throughput, however, increases by 70%, and the maximum batch size increases by 32%. And in the 3D setting, the downsizing factor increases to 512, the latency decreases by 62%, the throughput increases around 55 times, and the batch size increases proportionally to around 512 times. And we can also think of storage costs decreasing proportionally with the actual downsizing factor. So the main takeaway is that we have around 70 to 50 times improvement in throughput in these 2D to 3D tasks. So you can think of this as really promising, especially for potentially SSL experiments or images or training foundation models that require a large batch size that cannot always be accomplished in resource-constrained settings. We then want to evaluate how these downsized latents can be have high-fidelity reconstructions. So specifically to evaluate whether clinically relevant features are preserved in the reconstructed images using these kind of manual perceptual quality metrics, as well as automated ones too. And these evaluations, especially if we were to look at them, consist of evaluating whether the encoding and decoding process retains these relevant features. For quantitative results, I refer you to our MedVAE paper, which shows strong quantitative metrics on MSSIM and PSNR in both the 2D and 3D settings. But here we're going to show some results on using a qualitative reader study by using domain experts to understand the clinical usability of our models. And each reader was presented with a pair of chest x-rays, as you can see here, consisting of the high resolution image on the left and the reconstructed image on the right. And we saw a total of 50 unique chest x-rays with fractures. The reconstructed image was scored on the 5-point Likert index, ranging from -2 to 2. And our study involved 3 radiologists as expert readers. What we observed is that for the manual evaluation, the readers rated the image fidelity of the 2D MedVAE around 2.8 points higher than bicubic interpolation. So bicubic interpolations over here, and the 16 of downsizing factor. MedVAE is at the same downsizing factors up here. Bicubic is F is equal to 64 over here, and this is 2D MedVAE over here. And similarly for the three types of evaluation tasks, which consisted of fidelity, preservation of the relevant features, and artifact. And we see that 2D MedVAE better preserved the clinically relevant features, artifacts, and preservation of the relevant features. And these interpolation methods really suffered from blurring artifacts with these increasing downsizing factors. So in summary, our results suggest that the 2D MedVAE better preserves these diagnostic features than interpolation. So we've provided a lot of information about our work, but what are some of the main takeaways? First main highlight is definitely that we performed a strong evaluation across 20 different medical image data sets of various types, various anatomies, and different modalities. We showed that these downsized latents can replace high-resolution images in these computer-aided diagnosis pipelines while maintaining or even exceeding performance. These downsized latents also offer a 70% improvement in the 2D setting and a 50% improvement in the 3D settings, just in terms of throughput, really enabling large models to be built using latents instead. And we also show that we can have effective reconstruction using these VAEs. So to preserve these relevant features that can be used necessarily for interpolation, interpretation by radiologists. So if we really think about it in a future pipeline, like if people were to use it, then you may just need to store your actual latents, which you can use for model training, and actual storage. And if you ever want an interpretability of the latents, you can also always use the decoder to decode it back to the high dimensional setting of your actual image, and try to evaluate and make any sort of qualitative assessment from there. And definitely in our future work, we want to look at more foundation model scaling tasks using these latent representations in resource constrained settings. So we have, not all academic centers have resources, but a lot of people want to build foundation models. Perhaps MedVAE can be used as a tool to enable that and actually allow researchers in all settings to be able to train and have access to a large and a rich data set. You also want to think about maybe potentially adding additional training strategies for higher compression factors. There's always ways to improve on our results, and thinking about these strategies from a first principles perspective may actually allow us to uncover even more power from our latents. So I wanted to thank everyone for allowing us to be here and present our work. We have our paper on archive if you want to read. We're also presenting it in a couple of weeks, as Maya mentioned at middle. We also specifically have a nice, easy to use inference engine and a streamlined fine-tuning pipeline on GitHub. To use it is actually fairly simple. You can just load in some basic packages. Our MedVAE package is actually pip installable. So if you wanted to load your image, you can just put in your model as MedVAE and choose whichever MedVAE model is in there, because it's a family of models. And you can kind of choose which modality you exactly want it to do. So you have a corresponding image transform as well with our image. And you can effectively use this pretty natively in your own inference pipelines, or even we have a separate fine-tuning pipeline as well in our GitHub. So please feel free to check it out. We've also been excited that there's been considerable interest in the community already. We've had around 8,000 downloads so far, and we're excited to see what everyone else is able to do with it. So just thank you. I suppose we'll open up for questions now.
Fantastic. So let's take two questions. The first question came asked when during the one of your first slides, I think it was the 2D downsized latents slide. The question that came in was, could you explain again what the projection layer is and why you wanted to fine tune it during the second stage?
Yeah, for sure. Thank you for that question. So the projection layer was specifically introduced to project those latents into a new representation space that was better aligned with the features of the original input image. So the way we've set this up is that first stage of training will really focus on maximizing reconstruction quality, right? So we want a very high quality encoder and decoder. And then that second stage will specifically look at fine-tuning that latent space in order to create latent representations that more effectively capture key medically relevant features. And the way we determine whether a feature is medically relevant or not is by using that embedding space of biomed clip. So we want to see that those embeddings, when we project those latents, are identical to the embeddings of the original input image in that biomed clip latent space, which would suggest that we've captured those clinically relevant features. And so in practice, the projection layer is very lightweight. It just takes the form of three 2D convolutional layers with ReLU functions in between. And that's the only part of this model architecture that's tuned during the second stage of training.
Fantastic. And then we'll take one last question here. How were fractures understood for the purpose of this study? Were these fractures which could not be identified through visual means?
Yeah, yeah, I can answer it. So I can talk about it in the 3D setting. So these fractures, I actually manually looked at some of these fractures, and you can visually identify some of them. So they're not super fine-grained fractures in which they're not fully noticeable. But what they do have is that they do span multiple slices. So it does allow us to assess whether the fracture is, if in just one slice, you kind of lose that information, or whether if you use a lot of these 3D approaches, it's able to actually preserve that volumetric consistency of having that fracture span a multiple slice. And so some intuition as to why interpolation may not work as well as like these 3D models, perhaps. It's just that that fracture that spans multiple slices is effectively compressed, and that signal is reduced as to what a fracture really is, whereas the 3D approaches really highlight that component for being used in the fracture. Additionally, like there's also really varying types of fractures. So it's not just your typical like break, especially in the spine CT fracture task. There are often wedge fractures or different kinds of like compression fractures too. So it's not always fully clear, but it's nice that our models are able to learn these different types of fractures, even using these latent representations.